I'm going to move on to our third speaker in this session, our colleague who truly needs no introduction. Dr. Wagh has been here at the University of Colorado since 2015. He is extensively trained in Boston and Chicago and Indiana before he came here. And he really has been our expert in third space endoscopy. And we also rely on him very heavily for all things surgical, endoscopic related, and tissue apposition related, as he's the head of our endoscopic surgery and tissue apposition division in the section. It gives me great pleasure to introduce him today. What he wants to talk about are strictures, fistulas, and leaks, what an endoscopist can do to preserve the colon. Mihir, thank you.
Thank you, Steve, and thank you to Sachin and Raj and the organizers for inviting me. So I'll get started, and in the next 15-20 minutes or so, I'm going to be talking on what an endoscopist can do to preserve the colon in the setting of colonic strictures, fistulas, and leaks. And there we go. So the agenda will include talking about, in the first part, on colon strictures, both benign and malignant. Then we'll move on to fistulas and leaks. And in that process, we're going to talk about the devices that are available. Most of us are familiar with these devices. And in the interest of time, I will not focus much on balloons and through the scope clips. I think those are pretty well established, but I will talk about knives for stricturoplasty, the role of stenting, suturing, and then end with something a little newer, which is endoscopic vacuum therapy. So let's get started with benign colonic strictures. And as you know, that balloon dilation is the standard endoscopic treatment of choice. And if that fails, electroincision or stricturoplasty can be done, which traditionally used to be done with a needle knife, but now with the availability of ESD knives, like hook knife and other knives, this can be done with that as well. I should make a note that colon stents are not recommended as permanent therapy for managing benign colonic strictures. Another technique that I want to bring up is electroincision and doing a radial incision and cutting technique, which has been described for refractory benign esophageal strictures. And this technique has been now used for the colon as well. And I think I'm going to use a pointer here. Hopefully that'll work. Right. So the technique is to do 4-quadrant incisions and then connect those incisions with radial cuts to basically open up the lumen. And this has been described in some case series recently on using for doing stricturoplasty in the colon as well. Let's move on to stenting for benign colonic strictures. I should start by saying this is a controversial topic, can be used as a second-line treatment in case of failure of balloon dilation and stricturoplasty. So I do want to say that this is not something that we recommend routinely. It's a decision that has to be done on a case-by-case basis. The efficacy of stenting is lower for benign disease than for malignant obstruction, and it is effective in the midterm or short-term period with success rates in the 36 to 76% range. I do want to say again that these stents do need to be removed typically in a few weeks, but stricture recurrence is often seen up to about 50% of cases after stents are removed. Complication rate is about 23%, mainly migration and perforation related to stenting of these strictures. Now let's talk about malignant colon strictures. This is the main indication for colon stenting. And let's focus for a brief period on acute malignant colonic obstruction. 1/4 of colorectal cancer cases will present with acute obstruction. And typically the treatment is surgical decompression, which includes the primary resection of the tumor and a colostomy at the same time. Many patients are not able to undergo a reversal, so this colostomy becomes a permanent stoma. And emergency surgery in this setting is associated with higher rates of adverse events because of the coexisting electrolyte imbalances, nutritional deficiencies in the setting of acute obstruction, and the chance of fecal contamination in an unprepared bowel and anastomotic leaks. So what can we do to help in this situation? So colon stents, I should say again that these are uncovered stents. They're designed for palliation of advanced cancer, and they are used sometimes as a bridge to surgery where the stent is placed, and then that allows a future performance of surgery with a one-step, one-stage primary resection and anastomosis. So how this is done, here's a malignant obstruction. There's a mass, a guide wire is passed across it under fluoroscopy, and then the stent is deployed. And you can see here the distal end of the stent after it's deployed. The stent is nicely seen opening up the stricture on a CAT scan as well. So how effective are these colon stents for malignant obstruction? Technical success and clinical success around 90% or so. Median patency about a little over 3 months. And the reintervention rate for these is about 20% as well. I do want to point out that adverse events in the setting of acute malignant colonic obstruction is about, perforation rate 4%, migration 12%. We don't have covered stents, but these have been used. And in that case, the rates of migration are even higher, maybe even as high as 50%. Let's talk about the next kind of controversial topic, which is colon stenting as a bridge to surgery. And the concept here is that the bridge to surgery approach allows the bowel to be decompressed to stabilize the acutely obstructed patient. This then allows elective surgery with an adequate bowel preparation, and then a one-stage surgery, which is primary resection anastomosis without need for a stoma. So I'll share 2 randomized control studies with you next. The first one is a Dutch study from at 25 centers. 98 patients were in the study, 47 in the stent group, 51 in the emergency surgery group, and 2 interim analyses, the first of the first 60 patients and then of the first 90 patients, both showed an increased 30-day morbidity in the stenting group, and the study was suspended. At final analysis, there was no difference in the mean global health status, mortality, and stoma rates. Technical success was a little low, 70%. Perforations were seen in 13%. And when they included some silent perforations that were detected on surgery in the resected specimen, the perforation rate went up to about 19%. So this study suggested that colon stenting does not have a decisive advantage over emergency surgery. I'll now share with you a more recent multi-center randomized control study next. But before we talk about that, we do need to look at some of the limitations of this Dutch study. The stent was placed by endoscopists who had placed around 10 stents. So again, their experience is not really clear. The perforation rate was much higher than what is noted in other published literature. And the technical success was also low at 70%. There's also some concern that there could be some oncological consequences of silent perforation and the spread of malignancy that was not studied in this study. So the next randomized control study will hopefully shed some light on these questions that came up from this earlier Dutch study. So this was a study where patients were randomized to stent as a bridge to surgery. There were 56 patients in that arm. 59 patients were in the emergency surgery arm. Technical success was 87%. There were 8 stent-related complications, but overall complications, 51% in the stent group and 57% in the emergency surgery group. Those were pretty much similar. And I think the higher rate seen here is because of this acutely ill patient population, where they're prone for multiple complications not necessarily related to the stents. what they found was that there was no difference in the 3-year survival rate and the progression-free survival in both groups. And the difference they saw was in the stoma rate. So 19.6% in the stent group ended up with a stoma, as opposed to 38.9% in the emergency surgery group. And the stoma reversal rate was about 1/3. So this study concluded that the two treatment strategies were equivalent. There was no difference in oncologic outcomes in the two groups, and there was a significant lower stoma rate with stenting as a bridge to surgery strategy. I'll quickly show you one slide on extracolonic malignancies. We often get called to place stents when the colon is extrinsically compressed. And this is a study looking at this very issue. This was a retrospective study. There were stents placed for colorectal cancer in 34 patients and for extracolonic obstruction in 15. The success rate was 94% for cancer patients and as low as 20% in patients who had extrinsic compression. Complications, again, 8.8% in the colorectal cancer group and 33%, much higher in patients who got the stent for extracolonic malignancy. And they concluded that stenting for obstruction from extracolonic malignancy is infrequently successful and is associated with higher complications. With this, let's move on to the next part of my talk, which is addressing colonic fistulas and leaks. And leaks and fistulas can occur in up to about 20% of patients. And we do have endoscopic options available consisting of stents, clips, suturing. Dr. Repici showed you a nice example how the overstitch device can be used to close defects. And some of these can be used for these fistulas and leaks as well. And then there's endoscopic vacuum therapy, which I'll touch upon at the very end of the talk. I do want to mention again that fully covered colonic stents are currently not available, and esophageal stents have been used. I'm not going to go into that area for now. Many times these stents are fixed either by suturing them or more recently with the stent fix over the scope clip device that has now become available. So here are some photographs, endoscopic photos. Here's a colon fistula. This is then covered with a stent, and the stent is then fixed with the overstitch device. Or more recently, we have been using the stent fix over the scope clip. So what is the role of stents in managing these colorectal complications? This is a systematic review. 32 studies were included. And what I do want to share with you is that the early success rate was 73%. But when you looked at long-term success, it came down to almost 57%. So again, complications high 31%, migration as high as 41%, but long-term success rate was not as high, again, around 57% or so. So to manage these fistulas and defects in the colon, the over-the-scope clip has become available. And we have been routinely using this. Here's a fistula. This is treated with APC to ablate the tissue to promote tissue healing. And then the clip is placed to approximate that site. Another way to do it is with a similar over-the-scope clip device. This is the padlock clip. The principle is the same, to ablate the tissue and then place the clip to approximate the fistula opening. So how do these clips perform? So this is a multi-center retrospective study. 188 patients were included. There were 50 patients with colorectal defects. Long-term success was seen in about 2/3 of these. And what's important here is that the rate of closure for perforations and leaks, as you can see in these two left bars here, was significantly higher than closure of fistulas. In the interest of time, I'm going to go through the next slide quickly. Multiple studies have looked at the OTSC clips for closure. Most of them look at short-term closure. Long-term studies are limited. And here's one study that showed that initial success, even though it was as high as about 89%, 46% of these patients developed a recurrent fistula over the long term. And the reason that they might have not healed or not closed the fistula is especially if the fistulas are chronic, fibrotic, they have retracted edges, often in a radiated field, and if the tissue site has not been ablated with APC or something similar, then fistula closure may be a problem in that situation. I'll just skip over this slide on suturing. We've talked about it, seen that, but let's see how effective this can be if we combine these modalities. And I'll share with you a quick study here. This study included 51 patients, and overall closure of fistulas and leaks was seen in 55%. What is important here is that they looked at closure just with endoscopic suturing alone, or with just stenting, and then with a combination of suture plus stent. And as you can see here, closure in the combined group was much higher, 75%, as opposed to the two treatment modalities, which is suturing alone or just stenting alone. Stent migration was seen in as high as 40% of these patients, but surgery was avoided in 65%. So now I'll end with endoscopic vacuum therapy. This is a little newer way we've been handling some of these fistulas and leaks. We've been doing this now for esophageal defects and leaks at our institution. And the same therapy, the same principle can be used in managing these leaks in stable patients without peritonitis or sepsis, even in the colorectal. The mechanism by which this works is that the endosponge, what this means is that a catheter, typically an NG tube, we take an NG tube and suture a sponge to it. This is then introduced into the cavity or to the lumen at the site of the fistula, and suction is applied. And this creates a negative pressure, ensures continuous drainage, controls infection, stimulates blood flow, as well as stimulates granulation tissue. And over time, the cavity then heals and collapses around the sponge. So I'll show you a picture here. This is a leak at the site of a surgical anastomosis in the colon. There's a large cavity. The endosponge is introduced into it, and suction is applied. And every 3 to 5 days, the sponge does need to be changed. And as the sponge is changed, the sponge can be resized depending on the size of the cavity. Most often the cavity will reduce in size, and over time, you can see here there's nice granulation tissue and the cavity has all healed up. So I'll share with you the data supporting some of this. 16 patients, again, these are short, small number of patients in both these studies that I'll share with you. 16 patients treated with the endosponge. If you look at the two groups here, they had 8 patients who got the sponge treatment started within 6 weeks, and the other 8 patients had the treatment started beyond 6 weeks. And what they found was that the abscess cavity closed, the rate of closure was 56%, and the average number of sponge exchanges, the median number was 13. So you have to keep doing this every 3 to 5 days till the cavity collapses. Overall, closure rate, as I said, was 56%. But if you look at the patients who got early treatment, where it was started within 6 weeks, the rate of closure was 75% compared to those that got started with treatment beyond 6 weeks. This is the next study that I mentioned, just recently published this year. This was a prospective analysis of 18 patients. And mean time from surgery to initiation of endoscopic treatment was 16 days. Number of procedures that patients had per patient was 6. Complications were seen in 11%. I do want to say that bleeding is an issue that we have also seen, but that can be controlled endoscopically. Most often it's from the suction that goes along with this therapy. If there are any exposed vessels in that area, they can have significant bleeding. And long-term success with this endosponge vacuum-assisted therapy was about 83%. So my take-home points for this are that endoscopic therapy is a safe and effective option for patients with colonic strictures, fistulas, and leaks, and should be considered before a second surgery is recommended. Colon stents are designed for palliation of malignant colonic obstruction, and these stents are uncovered. Again, uncovered stents are not designed for removal. We often will get asked to place these uncovered stents for benign indications, and that has to be on a case-by-case basis with discussion with the colorectal surgeons. Stent placement for benign indications or as a bridge to surgery is still controversial, and in this case, the indication for stenting should be very clear. The management plan should be discussed. It should be predefined in conjunction with other specialties so that, once we place the stents, there is a follow-up that has already been decided for these patients. And lastly, I would say that the newer devices, over-the-scope clips, endoscopic suturing, stricturoplasty, vacuum therapy, or sometimes a combination, all of these have shown promising results. So with that, I'll end. And with this photograph, this is a foreign body in the cecum. I just did this case 2-3 weeks ago. This is a crucifix that had been around for about 5 years and was easily removed with a Rothnet, but was not done for 5 years for fear of complications during removal. So with that, I'll end and we can go into the discussion section. Thank you so much.